Uh, Welcome everybody. I'm very proud to participate to this hospital innovation webinar. It is my third part. I don't know if you were present for the two first session, but now it will be a little bit much more complicated regarding the different options we have with this pull-up system, this suspensory fixation system. So it's called the pull-up around the knee. That means that we can do many different things for the knee surgery, ever the ligament reconstruction or repair and tendon reconstruction and repair. That is all the program for today. We have already talk about isolated 4ST reconstruction and its variation. We will be very fast on this part, and we'll see after all these different options. You see that we have a big job to do today. Let's start for the first option for isolated ACL reconstruction, which is the main activity for ACL surgery. We can use first the hamstring tendon in different options. We saw this in the first session with inside-out technique, which is my favorite technique, but you can also, depending your habit and your surgical school, outside-in surgery or all inside, depending on different tunnel and graft insertion. That is the principle of the outside-in technique. I drill a blind femoral socket and an open tunnel on the tibia in order to insert the graft from the tibia to the femur. That is very important for me because it's the only way to save the remnant, and the remnant is a very helpful structure we have to save. We use a tricky thing, the graft tech device, to set the graft, and we got a flat graft which is mimic the native ACL shape, the ribbon concept shape. Don't forget to lock the two extremities of your graft in order to load the fourth strand of your graft. If you don't lock this, you will just have 2 or 3 strands loaded, which is not the goal. So beware to precisely make this figure of 8 stitch. You can find the technique in the arthroscopy technique website. It is a free connection website. That is a view we have of the graft. You see this is a flat graft. I recommend to stitch all the graft in order to get a global graft to avoid the insertion of joint fluid in between the different strands, which can disturb the synovialization of your graft. And synovialization, is the very important and first step of the graft healing and the ligamentization process. But we can also use the patella tendon with the same system. The idea is to respect a good femoral tunnel placement, because if you do this kind of ACL reconstruction with screw, because you need the bone at the posterior part of your femoral tunnel, you will put your femoral tunnel a little bit anterior, which is not very anatomic. The principal advantage of this is to push your femoral tunnel at the part. Even though you blow out the posterior part of your femoral tunnel, you don't care because the fixation is locked on the cortex. You have 2 different options for this, 2 commercial settings. The pull-up BTB, we will see that we have some some application for this, or the BT-loop pull-up, the new version, use with the graft tech system. That is the principle. The pull-up is not set at the beginning. You insert the 2 loop first in the one hole. You need to have 2 different holes. 1.5 diameter hole, that is a small tunnel, in order to respect the bone plug to don't lead to breakage of your plug. So small tunnel with distance in between each. You insert your thread in the black loop to introduce your thread in the finger, Chinese finger trap part of the pull-up. And you do the reverse for the second loop and introduce and reduce the system. We will see next with a video how does it work. That is the BT loop system. You clip this device on the graph tech, and it is a very helpful thing. You can do it alone, one person, but with the pull-up BTB, you need two people, you and your assistant. But with the BT loop, you can do it alone. That is a movie of the this setting. First, this is a real time, no cut on the video. You will see it's a very fast and effective. You insert with a suture your thread through the first hole, distal and proximal. You don't care, it's not important. You insert this thread in the opposite black loop and insert with a small motion. That is done, the thread inside the loop. Then don't forget to lock this first loop, because if you don't, when you will track on the second black loop, you will track the pull-up with you, and we will not have any resistance to go to the correct insertion. At that time, if you don't lock the first loop, you will be in trouble. And track a little bit, and that is done. You see, that is a really simple thing to do. Reduce your loop to 4 centimeters, and now it's done. Now let's move to a much more complicated thing, that is a combined ACL reconstruction, combined with a lateral reconstruction, lateral or medial. The graph setting is the same for both techniques. The principle is to reproduce what is work, which is 4ST pull-up for ACL reconstruction, and just link something more than this. So in all the cases, you will have your ACL reconstruction locked in the same manner that in isolated ACL reconstruction. And I link to this 4ST a 3G, free gracilis strand graph, using a pull-up standard at the extremity, and the link device is the pull-up text. Pull-up text is the pull-up without any platelets. And we got this kind of graph. You see that's a very nice graph for the lateral reconstruction. The 3G is rather big graph, flat, which is very helpful, especially on the lateral side because the ITB. And we have a 4ST, sometimes 5ST graph for the ACL reconstruction. The insertion of such a graph is made from the tibia to the femur, and after that you lock your 4ST graph and finalize your ACL reconstruction. Then you go under the ITB with your 3G graft and return to the second tibial tunnel just behind the Gerdy tubercle. That is my opinion. I don't do this at the native insertion of the ALL if it doesn't exist. I prefer to go a little bit anterior in order to better control the internal rotation of the tibia. But you can use the same setting, exactly the same setting, for the combined ACL and MCL. In some chronic cases, you cannot repair the MCL, and you have to do reconstruction. But in that case, you use this graft in the opposite way. You insert the foresty extremity to reconstruct the ACL, lock it, and then go to the femoral, up to the medial femoral tubercle to reconstruct the MCL. Think about putting your tibial tunnel external aperture a little bit posteriorly that I recommend for the isolated ACL, because in that case, if you put it too close to the TTA, you won't be in the direction of the native ACL, which was described very well by my friend James Robinson, which is probably online, and I tell him hello. So next is the ACL repair. ACL repair is used in young patient in a tibial spine fracture, and you will see that it's very tricky thing and simple thing. 4 different steps in this setting. First, you have to enlarge your loops, pull-up loops, from 4 cm to 6 cm. Next, you move your platelet from the initial position to the extremity of your pull-up. First step, put a suture relay through the loop in order to control this distance when you will insert the system to avoid the reduction of your loops. The fourth step will be to use the pull-up clip, which is an additional thing, an additional device to lock the pull-up. We will see the technique. So that is the tibial spine fracture. You first do the same thing as usual, clean out the loss of your bone block, and use the hammer to reduce the fracture before to drill the tunnel in order to lock the bone plug and to go through easily. So do this reduction by tension. The tunnel is very small, 1.5 or 2 millimeter diameter tunnel, which is very small, and respect the bone plug, because if your tunnel is too wide, you will expose your bone plug. Sometimes the bone block, is rather small, so do a small tunnel. Then use a Hewlett key Y to insert a suture relay. You get it out from the instrumental portal of your arthroscopy to insert your pull-up from the inside to the tibial tunnel. Then put the clip in between the two loops and retract slowly to reduce your bone fracture. That is an X-ray view and an arthroscopic view. You see that it's a small device, and the interest is that you track your fracture and your ACL in the direction of the ACL. I mean that if you use a screw for such big bone plug, you will put your plug a little bit posterior, and at the end, under arthroscopy with your probe, you will see that your ACL is slack. But in that case, it's tightened, and it's very, very interesting. And in some cases, you have two bone block. You can do two different hole and two different systems. That is the case on the picture on the left side. But one of my friends used it for the PCL bony avulsion, which is unusual, but sometimes you can have, and a very small thing going through the phases. And you see that's a very nice reduction and nice surgery. Next is the ACL repair. I talked about this in the last session. for the young female patient, but it's also very interesting for all the patient in rather acute condition. The principle is to tighten your remnant in order to cover all your graft and allow to a better healing of your graft, and to avoid the retraction of your remnant, providing a cyclops syndrome sometime. So that is the principle. You drill your tibial tunnel and stay inside your remnant. Put some suture, 2 or 3 sometimes. Put your remnant inside, track your remnant inside the tibial tunnel in order to make your notch free, to better place your femoral tunnel, because saving remnant is not easy for beginners, because your notch is not completely free, and it's difficult to see and to do a good placement for the femoral tunnel. So in that case, track your remnant inside the tibial tunnel, which make your notch free, and it's really better for this kind of surgery. You insert your graft from the tibia to the femur, tighten your graft at 20 degrees of flexion, then little by little you tighten your remnant, and you see that in that case I did, the remnant was healed on the PCL. I removed slowly with a smiley chisel. I removed slowly carefully the remnant, then put it some suture, and you see on the D picture the perfect and global view of this. You have also this technique on the arthroscopy website, open access. Now a little bit much more complicated for expert, this 6 different options from the PCL to the quad tendon repair. So let's start for the PCL. This kind of graft, 4 ST, sometimes 5 ST, set on the pull-up system, is very, very effective to reconstruct the PCL. I promise you will see that it's a wonderful, it's a great pleasure to do this. The setting of the graft is exactly the same than we do for 4 ST ACL reconstruction. And it's easy to track your graft from the tibia to femur because you don't have any plug, bone plug, to go at the posterior part of the tibia. And after inserting the graft inside the femoral tunnel, you lock it, and then you put your knee at 90 degrees of flexion, and little by little, with tightening your tibial pull-up, you precisely control your posterior draw reduction, which is very, very nice to do. You will see this is a very exciting technique. That is the picture we have in X-ray, and the arthroscopic view. You see that the PCL is a cone shape as we see with a normal PCL. It's a nice view and excellent surgery. So much complicated, it's a PLC reconstruction. That means that it's a combination of lateral collateral ligament reconstruction and popliteus reconstruction. For that, I use ST put in 2 strands above and through the standard pull-up, and with 2 sutures at both extremities. That is a graft setting. We drill 3 tunnels for this reconstruction. One on the femur, just under the lateral femoral tubercle. The second one in the tibia, in the lateral tibial plateau, AP drilling, and the third one in the head of the fibula. We track the graft from the femur to the tibia, first going through the femoral tunnel, Then inserting 1 centimeter, 0.5 or 2 centimeter of graft, not more, in the tibial tunnel. You tighten slowly your pull-up, not too much. Then you will insert your tooth extremity mimicking the LCL, and these two sutures are not over the fibula head. Then at the end, after cycling your knee, you tighten your pull-up in order to set all the system. It's a beautiful technique coming from the Laprade technique principle, and it's very effective in some very severe cases. More complicated is the posterior medial corner reconstruction. A combination of the MCL and POL reconstruction, because POL, as James shown us, it's a very important structure, probably the most effective structure for the lateral laxity, medial laxity control. The MCL is effective, but not the most important. The most important controlling this is the POL. POL must and have to be reconstructed in some severe cases, and especially for chronic lesion. How we can do? First, we put a pull-up in the middle of your ST. You let the ST attach on the tibia. Put 2 or 3 sutures, then put a standard pull-up at the end of your graft, and the setting is done. Then you drill 2 tunnels, one on the femur, just above the medial femoral tubercle, and the second one under the medial tibial plateau, the AP drilling. You insert your graft on the femoral tunnel, you tighten it after some cycling of the knee. Sometimes you have to put a staple on the, I don't know if you see the arrow, on the tibia, in order to change the direction of your graft, because the bony attachment of the ST is sometimes a little bit posterior than the insertion of the superficial bundle of the MCL. Then you go under the semimembranosus and inside your tibial tunnel. You tighten your pull-up little by little, and next step is to lock your graft on the medial meniscus as the deep bundle of the MCL do. It's very important for the behavior of your graft, and one thing is to suture it to the meniscus, and the second is to cover your graft by the remnant of the MCL to provide a vessel for its healing. Next is dedicated to the tendon of the knee. First, the patellar tendon. This technique was also reported, case report in orthopedics. It was for a patient, you will see the case later, with revision of the first repair, and but you can do in acute condition, especially for all patients or for high demanding sport patient, the competitor, for example. You protect your suture with a non-absorbable suture or ligament augmentation synthetic structure, and then you insert 2 pull-up through the patella with a small hole, 1.5, very small hole, and through the patellar tendon, and it's better if you have some bone. The resistance is better, but it's not important, and you reduce this. That is a case I told you. It was a professional handball player. He had a long time of tendinitis, chronic tendinitis of the patellar tendon, a very big muscle, big quad. It's an incredible big quad, and went to another center for surgery for his rupture, and the surgeon did reconstruction using semitendinosus graft, and the tunnel on the patella was probably a little bit too distal and too big, and lead to a rupture of the patella. So I use this kind of system, and you see the MRI and X-ray 18 months later with a rather good healing, and he returned to his professional activity and was very pleased with this, because his career was very compromised by this kind of lesion. Next step, the patellar tendon reconstruction. Because in some cases, especially for old patients, you have a very bad chronic tissue unvasculated, and so you have to provide some additional tissue because the native tissue is not good enough. So in that case, you can use a standard Foresti graft, the same then for ACL. You just drill two tunnels, one on the patella, one on the tibia, and in that case you will insert your graft as an all-inside technique. First on the tibia, you lock the extremity, second on the patella, and reduce your loop and control your reduction. Then you can put suture on your remaining tissue of the patellar tendon. It is very interesting and helpful in chronic old patient. That is the technique, the graft set, insertion on the tibia, insertion on the patella, and the reduction. That is the X-ray view. I put a staple in addition to save and protect the traction of your pull-up, because sometimes the bone is not good enough, and the reduction is excellent. The last thing is the quad tendon repair. That is also interesting in sport patients, but also in old patients. The principle is to drill 3 small holes in the patella. If you use a small hole, you are protected against the bone fracture, because when the bone are too big, you can have a complete fracture of your patella. The small, that means that's 1.5, it's rather small. Then you use in that case pull-up BTB and not the pull-up BT loop. That is the BTB. You insert from the patella to the tendon, go through the tendon rather high to get a good tissue, come back to the medial hole on the patella, insert in the thread, in the Chinese finger trap part, do the reverse thing with the extremity, and track to the second pull-up Chinese finger trap. You reduce the system. One tricky thing, because you have to go through the tunnel many times. So you put in suture relay first with your KY in the hole and in the tendon, and this suture relay is linked to another one with 2 knots at the extremity. So you have 2 loops connected with because you track in this way, track in the other way without any trouble. You can do this many things, especially in the medial hole, because we do the same with the second pull-up device. It is a very tricky thing. You don't have to go through many times. You return to the same tunnel very easily. Then you redo your 2 loops, and put a suture above this. That is a surgical case to finish. We clearly see the rupture of the quad tendon. We don't need to examine the patient. But it was an old patient, very active. It was a minister, French minister. And I did this, as you can see, and he had immediately a good quality to continue a good program of rehabilitation. So I thank you very much. I'm waiting for your question. In my hand, because I promoted the hamstring surgery. I've been promoting this since now 20 years. I'm much more comfortable with hamstring, but there are many advantages to use hamstring because it's a modular graft. You can get the good graft you want. I mean that for example, for a big guy, heavy and active, we have in a rugby player in southwest part of France. Sometimes we have a rather small tendon. So in that case, we can do 5 loops for the graft, and sometimes we can add the gracilis also. So whenever the patient morphotype heals, I will get the graft I want to match my graft to the patient. And that is very interesting. That you cannot do with the BT, with the patellar tendon. With the patellar tendon, you have one graft and you cannot change anything in terms of length, in terms of diameter. Because if you take too much graft, you will have a very bad patellar tendon remaining and the risk of rupture of your patella. That's came for some patients. So the first advantage is to have a modular graft. The second advantage is that it is a very simple and fast surgery. But for who use a patellar tendon in routine, it's no problem to use this with the pull-up system. I told you that the advantage is to put your tibial femoral tunnel in a good way, in a good situation. You cannot get the perfect position if you don't do an outside-in femoral tunnel. So in my case, the indication, it was the question, was in revision cases, I use patellar tendon, but in some patient, for example, for some football players, but I think that it could be much more interesting to add something else to your graft instead of to be much more confident in patellar tendon instead of the hamstring tendon. Probably the patellar tendon is stiffer than the hamstring, but for me it's an option because I cover a large part of my patient with a simple and very effective surgery, the 4ST hamstring reconstruction surgery. I've been using this since 6 or 7 years. I didn't do a lot of patient because it's not the majority of patient, but I did 72 or 73 cases, which is rather big in this 7 years, and with good success. But for such a patient, the indication should be discussed because sometimes we have to do an additional osteotomy. in chronic cases. But what is interesting, in some acute cases, you protect your repair with such a reconstruction, and it is rather interesting and effective. But it's complicated surgery, and it is a controversial surgery. For the PCL, the big advantage is to use a fixation far from your anchor point. I mean that if you use hamstring with screw, yeah, on the femur, no problem. It's easy because you see your screw under arthroscopy and you control everything. But what about on the tibia? Because the graft is rather short, and you have to put your screw far where you don't know exactly how much graft you grab with your screw. You don't know exactly. So the quality of your tibial fixation is not secured. But with the pull-up, you have a very strong and good fixation on this tibial side, and it's really very, very, very effective. You don't, because with the screw sometimes just at the surgical time you have a good feeling. It's perfect. You're very happy, but with time, month after month, you see that your posterior draw return, but with the pull-up, not. It's a very stable thing. There is a risk of bone fracture or bone plug fracture. So that's the reason why you have to drill two small tunnels with a distance, not only one tunnel, a big tunnel, because you increase your risk of fracture. And if you save enough distance, and I mean that's the plug length have to be 2 centimeters in order to well control it. If you don't, you have an option to put a pull-up on the femoral side, because it's a very important thing, as I said, to respect the position of your femoral tunnel with inside out tunnel, and you can put a screw on the tibia, but to avoid some breakage, respect this small tunnel 1.5 and with 1 centimeter or 1.5 centimeter distance in between both tunnels. And think about doing the proximal tunnel just close to the tendon attachment, because the bone is very dense and hard in this situation, and your fixation is better, especially in women. Not at all, never, because many different things. First, you have to clean out very precisely all the part of the fracture on the tibia, because if you don't do this, you will have a thickness, and you can have impingement with the notch, the roof of the notch. But if you do this, you control that your bone block return to the native situation. After that, the plate is very thin, and you track and insert it in the bone and in the soft tissue, and you don't have any thickness of this. But after a while, if sometimes for patient with hyperextension, the hyperlax patient, if you have some conflict or something with the blade, you just do an arthroscopy, you cut and track and remove very easily this. I didn't do, but it is an option. But the only case you can have some issue of trouble is the patient with hyperextension. Beware to save a rather good flexion. If you tighten too much, of course, an extension, you will reduce the length. And for the rehab program, the patient will tract very strongly on your repair. So then you only at 100 degrees of flexion, 105. And tighten your system at this level. That will be good. But don't do it in the extension. This is a very good question. That is the interest of one of the many interests of the pull-up is you cycle your knee, and if something happen and your graph becomes slack, you can tighten it again. It is not the case with the screw. You have to remove the screw, tighten, and that could be damageable for the graft. But with a pull-up knot, you tighten a little bit, both sides, cycling, testing with the problem in arthroscopic view, and that is very easy. It is one of the good advantages of the system.